Okay, dear colleagues, it's now 10 past 7. We are a bit later because apparently the Pentalfa server totally crashed because of the millions who want to view us today, this evening. We are only available now, viewable directly by the YouTube channel on internet. But this session will be recorded, so there is always a possibility to view the presentations on a later time. Okay, on behalf of the University Hospitals of Leuven, it is my great pleasure to welcome you all here for this special Pentalfa symposium on the new coronavirus disease. It's a special symposium because there is no live audience, not here in the auditorium and not in the external locations. It's only by live stream, if it is reachable, so that everyone can stay in their cot. It's also special because this is probably the first Pentalfa in English, and this we decided to do it in English because there is a lot of interest from the people of the French-speaking part of the country, and also even from outside Belgium. And last but not least, as you have noticed, this is probably the Pentalfa Symposium undoubtedly viewed by the largest audience, as we have this afternoon already we had more than 1,200 registrations. So, in cooperation with the departments of microbiology, radiology and general internal medicine, myself, at the Department of Pulmonology had the idea to organize this symposium on COVID-19 disease. And we think it's rather appropriate because doctors today are still confronted with a lot of questions, uncertainties regarding this disease. And this symposium, well, we will try to give some answers to these problems. Now, the symposium is divided upon three parts. The first part will tackle the making of diagnosis. The second part will be about management of disease with emphasis on antiviral strategies and the management of patients in intensive care. And the last part will be on the long-term follow-up, what happens to the patient, to the lungs, after having recovered from COVID-19. Coronaviruses are animal viruses with bats, wild bats being their natural habitat. And we know already that some of these viruses have made the jump from the bat to the human and are living now already several years rather peacefully with humans. They are the cause of mostly minor upper and sometimes lower viral respiratory tract infections. These are in green, the good ones, the good coronaviruses. And people were not that concerned about coronaviruses. But this all changed after the year 2000 when the bad coronaviruses came. And we know the SARS coronavirus and the MERS coronavirus who gave rise to rather small epidemics in 2002 and 2012. And now we see the emergence of the SARS coronavirus 2 with COVID-19. The bad coronaviruses, and now people start to get very worried about coronaviruses in bats. And I can tell you there are still more than 5,000 species in bats waiting to jump. This is the time frame. It all started in the end of last year, and by the 11th of March, the WHO declared coronavirus disease a global pandemic. It's less than 1 month ago. And yes, if you see this map, you can appreciate that the virus is in all continents, in nearly every country is impacted by the virus. The Belgian situation, we can follow this in social media and online and on television each day. We are now nearly with 25,000 people confirmed infected by the virus and nearly 2,500 deaths. We also have seen that the pressure on the hospitals is slightly decreasing, stabilizing, but we see that pressure on ICU still remains high, and we have to follow this up. Now, to end this introduction, I will give you 2 slides, a bit to set the scene for the following speakers. And this is the first slide, giving you a clinical picture of the COVID-19 disease in humans. And you can see there are 3 stages. The early stage with lesser symptoms, then a pulmonary phase with the symptoms of dyspnea and desaturation, lack of oxygen, and then in some patients, not all, but in some patients, the third stage, the stage of the most severe disease. And in contrary to SARS, for example, you see that the viral load is maximum in the beginning of the disease and decreasing along the further evolution, while the inflammatory response in humans is, of course, increasing with time, giving rise to the well-known now cytokine storm in the last phase of disease. And I show you this picture because it can make us ask about the performance of diagnostic tests and even therapies, whether done or performed in the several stages of this disease. You can ask yourself if the performance of a CT scan imaging of the lung will be the same done in the first phase or in the second phase. The same question you can ask yourself if antivirals will have the same effect when given early in disease or, as we do now, rather later in disease. So this is the first setting of scene, and the last one is a very short clinical case which concerns one of the first female patients in our hospital in Leuven here. It's an elderly woman of 76 years old with diabetes and hypertension, taking not a lot of medication, which presents already for some days, 4 to 5 days, symptoms, classical symptoms of fever, myalgia, non-productive cough and shortness of breath. She was admitted to the hospital, to the emergency department, with some slight abnormalities in the blood exam and with marked lack of oxygen, oxygen tension of 55 while breathing room air. This was the chest X-ray showing you bilateral shadowing of the lungs. And of course, in that time, earlier days, we did a viral swab of the nasopharynx and it was negative. So the conclusion was that it was not COVID-19. The patient was sent to the general ward and she was started on broad-spectrum antibiotics. But in the next 10 hours, she got worse. She became more and more short of breath and there was more and more desaturation. So she was sent back to the emergency department where we did a second viral swab of the upper airway and it was again negative. And then we asked for a bronchoscopy. We did the bronchoscopy with a lavage and there the viral swab was positive. So this was a possible case in the early days, and it highlights some problematic issues. The performance of viral testing regarding the place of sampling, also the chest X-ray, and probably the usefulness of a CT scan, and also makes you ask the question, what's the correct place, the correct timing for performing bronchoscopy. So this is a bit setting of the scene, and now I think we can start with the first presentation. Will be concerning microbiological testing of the viral presence in humans. It will be given by Professor Dr. Catherine Lacroix, which is, I would say, the right hand, perhaps also the left hand, and both feet of Mark van Rans here in our hospital. And so she is very well placed to give us this presentation. Catherine, first I will, no, don't come near me. I will first disinfect, like you see on television. We will disinfect all this, the mouse. So,
Thank you, Pascal, for this nice introduction and also for cleaning up everything here. So before starting discussing with you the performance of different diagnostic techniques, I want to show some results of a virological assessment of hospitalized patients in Germany. And these cases were enrolled because of infection upon close contact to an index case. They were hospitalized not because of their medical condition, but because this was the strategy at the beginning of the epidemic in Europe, like it was also the case in Belgium. And so the diagnosis was being made by a PCR on a nasal or oropharyngeal swab, and the earliest swab was taken on the first day of symptoms, which in these patients was mild or prodromal. And because all these patients were hospitalized in the same hospital, everything was standardized very much. And so let's first have a look at the viral load in relation to the days post-symptom onset. And so what is clear here is that the initial viral load can be really very, very high and is then declining during the days post-symptom onset. And so in this setting, all swabs were positive during the first 5 days of symptom onset, no matter if it was a nasal or an oropharyngeal swab. There was no difference in their setting, but after 5 days, really the detection rate dropped to 40% positivity. And they also questioned themselves about the infectivity of these patients. And so they did also virus isolation. And the good thing is that this virus is a virus that can easily be isolated from cell cultures. And so you see during the first week, part of the swabs, but nearly all sputum samples could be led to successful isolation of virus. But despite high viral loads later on, no isolates were obtained any further. And they had also another way to check for infectivity, and actually they went for the detection of subgenomic RNA, which is only transcribed in infected cells and not packaged into virions. So it's an indicator of actively infected cells. And so also this was only detected during the 5 days in throat swabs. They checked also viral load in urine or for the presence of virus in urine serum samples, but were not able to detect virus here in these samples, which is different for stool samples. In stool samples, high viral loads were detected, but also here, no or only minimal replication based on subgenomic RNA detection, and virus isolation was never successful in their hands, starting from stool samples. And so they also looked at the antibody response of this cohort of patients, and in 50% there was seroconversion by day 7, and in all patients by day 14. It's of course important to know if these antibodies are also able to neutralize the effect of the viruses, and this was the case. So this is just a detailed view of the viral load here in yellow in the swab samples, in orange in the sputum samples, and then gray the stool samples. Here is the period of cough or fever depicted, and then the arrow here shows the moment of seroconversion. And so it's clear that the viral load is declining clearly during the first week after symptom onset. Higher viral loads are seen in sputum and remain longer high. And there is also some variability in these patients. And I think Pascal already gave a nice introduction showing the difficulty of the nasopharyngeal swab PCR or the challenge. Indeed, you can expect that, for instance, if you have a healthcare worker that comes for a swab immediately at the first symptom onset, you can imagine that you are here in this time frame. But when a patient enters the hospital after being ill already for quite a while and then presents with pneumonia, you're later in the picture. So just another study, it's a cohort of patients who were more ill. The majority of these patients did have pneumonia from China. Actually, these were mainly patients who returned from Wuhan. And also here you see a similar picture, high viral loads initially and then declining quite rapidly. In their hands, there was a difference. The oral swabs, the throat swabs, actually the viral load was lower compared to the nasal swabs. So this could be due to maybe different sensitivity of the PCR or the technique the sample was taken. There was one asymptomatic patient during the whole course, but the viral loads in these patients were similar to the symptomatic patients. Of course, we all know that now that it's really difficult to get any swabs anymore, especially nasopharyngeal swabs. So people are looking for alternatives. And so in this group, they checked the performance or the usability of posterior, what they call posterior oropharyngeal saliva samples. Actually, these were 23 patients with quite severe disease, at least in 10 patients. And so they describe it as the patients were instructed to cough up the morning saliva. So it was only in the morning the samples were collected after a night rest, and the patients were instructed to cough up the saliva by clearing the throat. And so if you see here, you also get really nice viral loads in these kind of samples. Some of these patients, I think 3, were intubated, and in this time, of course, other samples had to be taken. Actually, these are the results of the endotracheal aspirate samples taken in these samples. It's not clear for me how easy the collection of these kind of samples is and how reproducible, but it's possibly an alternative. So for PCR testing of the upper respiratory tract, nasopharyngeal swabs are the preferred samples, but I think more data are needed for the comparison with, for instance, throat swabs or other alternatives. So from the graphs we saw, there is a decline of the viral load in the upper respiratory tract samples during the first week after start symptoms. So timing of sampling likely affects the sensitivity of your assay. There is no time to go into detail into the technical issues, but these issues are, of course, there. There are different PCR targets. It's necessary to include also an inhibition control and so on. I think also there are some issues also about the turnaround time of these assays. For the moment, it's still suboptimal. We would love to have faster PCR assays with, of course, also a very good sensitivity. There are some FDA, for instance, approved assays, but not broadly available yet. Just some data from our hospital. So just to show, because of the shortness of reagents, we have 3 different, let's say, PCRs running besides on different platforms, different extraction techniques. And so a similar way for looking at the viral load. You here have the CT value of the PCR, the lower, the higher the viral load, and the days post onset of symptoms. So what you see here is that the CT value depends on your technical issues, depends on the target and the extraction. So we can't lump together all our data, but if we just look at one platform, we see similar trend. So you see that the CT values are going up, so the viral load is decreasing if you are later in the course of disease, if you're later after symptom onset. So many people ask, what is now the sensitivity of the SARS coronavirus 2 PCR? I don't think there is a simple answer to that. This depends most likely on the sample type. The yield will be higher with lower respiratory tract samples, and maybe BL is probably the best sample type, but not so easy to obtain, especially not in these kind of patients. It will depend most likely also on the patient group. If you have an outpatient or a healthcare worker who presents with first symptoms of disease, or for instance, if you compare it to a patient who is admitted to the hospital with pneumonia. There, to really assess the sensitivity of your PCR, I think you need the results of your PCR. In this cohort of patients, you need a CT scan, and you also need an antibody test to really get a microbiological confirmation when your PCR is negative. We don't know yet, I think, but the underlying disease is, for instance, also something that might influence the sensitivity of your PCR. So I think certainly more and good data are needed. Considering the packaging of the sample, it's important to have your sample here in a container packed in a bag, and then add your request form and put this together in another bag. So your request form may not be in direct contact with your sample. And then it's important also to provide clinical information because there is a kind of triage of samples. There is a specific request form which is available on the website of Scienzano, and this is adapted regularly because the guidelines or the indications for testing change quite rapidly. So it is important that you go regularly to the website of Scienzano to check if you have the correct form. So on the website of Scienzano, you see the case definition and also the test indications, and it is important because the RISIF INAMI gave the information that they will reimburse testing, but only when it fulfills the testing criteria. And so on the same website, you can find a list of all laboratories doing molecular diagnostic for COVID-19 disease and other interesting information. So meanwhile, there's really a big number of labs in Belgium doing these PCRs. On the website you can find the contact details also of 44 labs, but there are more. Some labs preferred not to be on the website. So in total, we now have 55 labs doing these, executing these PCRs. So on this website here, you can find information about the molecular assays, but also the immunoassays that are out there now for COVID diagnostics. Well, you see here, if you look at the molecular assays, more than 200 results show up. So there are really many different assays out there, and the situation is not different for the immunoassays, the antigen, the antibody assays. Also, you see here hundreds of assays. I often, nearly daily, get emails, is there already an assay out to check for antibodies? Indeed, there are numerous assays out. It's more the validation now that is important. So let's switch now to the antigen detection, and I give just one example because it was developed in Belgium and also evaluated in Belgium. It's the COVID RESPI strip. So the principle is easy and it looks a bit like a pregnancy test. Of course, this needs to be performed in a biosafety cabinet. In a tube, you need to add a buffer and add a sample, and then insert a strip, and after 15 minutes you can read and check if a control line, but of course also the test line is present or not. And so it's a highly conserved nucleocapsid protein antigen that is detected here. The problem a bit with this kind of assays, well, the performance is a bit similar as for influenza, and you will see this here. This strip was evaluated retrospectively by 3 different centers, and so the specificity you see of this antigen testing is really excellent. So if your result is positive, you really can rely on this result. But the sensitivity in general is rather poor or moderate, let's say 60% at best. And this is also the problem, for instance, if we look at influenza antigen testing, we know also that sensitivity there is very much limited. So just the numbers for the cohort we tested in Leuven, actually we had nearly 100 samples. From 2/3 were from patients with a suspicion, clinical suspicion of COVID disease, and 30 from healthcare workers. And so when you start doing antigen tests on all these samples, actually we had 14 positive results. So for these 14 samples, you just can report and you do not need to proceed any further with PCR testing. Of course, in this study design, we did PCR testing and all these positive results were confirmed. But so in the majority of your samples, about 83% of your samples, you need to do, in addition to your antigen test, also a PCR test, which really adds on, of course, the work. And so this points to an important issue. Actually, due to the moderate sensitivity, you can only use such a test in really a very high, in a setting with really a very, very high prevalence of the disease. And it's not so easy, I think, to delineate a patient or a population where such a test can be useful, especially if you look, for instance, at the Belgian data, the number of positive tests or the rate of positivity rate, you see it was highest, let's say a week ago, but now positivity rates are already declining. There was a lot of attention, and still is in the media, about blood tests for antibody testing. Well, as you see, there were, as I showed, there are already more than 100 of such a test out. We started to do some validation of part of these tests, and I just show you some preliminary results. Actually, you see the specificity, and for that we really took a challenging panel, not just randomly selected sera, but sera from patients with other viral infections like EBV, CMV, but other coronavirus infections, also the endemic ones that Pascal showed in the introduction. And so the specificity in general, especially from the IgG test, is excellent. And so also for the sensitivity, we checked the seroconversion rates, and you see here after the second week, there was already in more than 60% IgGs were detected, and by 70 days we detected IgGs in all these samples. So it seems that several of these assays do have a good performance and will be quite useful. So there are different formats. You have the rapid lateral flow assays versus the ELISA assays. The ELISAs are more appropriate for testing large batches of samples. I think these antibody assays certainly do have a diagnostic value. They can provide you the microbiological confirmation in a patient with in whom the diagnosis was made on CT scan only. They can also give information about the proportion of the whole population, different populations that were infected, which might be helpful for policy makers. This will also help in profiling the spectrum of COVID disease. We don't know actually how many patients do or people do have a subclinical infection or an atypical presentation, and will also be helpful to get a better knowledge about the prognosis. But of course, much more research needs to be done. Can people with antibodies be considered as immune, and how long will immunity last? Do people who have mild or no symptoms, do they gain the same protection? Will the virus mutate to overcome the body immunity? Well, many questions around, I think. So we already got a letter from the RISIF, the INAMI, to say that these serological tests will most likely be helpful in a next phase. But up to now, there are no clear guidelines to use them, and only when these guidelines will be published on the website of Scienziano, we will be allowed to use these tests, and we will get the restrictions how to use them. So, thank you much for your attention. I think we will now go to the next presentation.
Okay, thank you, Katrien. While I disinfect your surfaces. Well, not your surfaces. Yes, I have one short question for you. Something that, just a short question, perhaps a short answer. For us pulmonologists, if we do a bronchoscopy, and Professor Dooms will give a talk about the bronchoscopies. If we do a bronchoscopy and we do a lavage, and we do a PCR test on lavage, which is negative, can we then be sure that the COVID-19 disease is excluded?
So, according to my knowledge, there is no data yet available based on studies to really answer this question. But considering the excellent sensitivity of PCRs and the fact that you take a sample at the infection site, I expect that the answer will be yes. But I think this need to be evaluated, during the next months. But of course, there are not so many bronchoscopies being performed in this population, so we really need some time to get experience with that.
Okay, thank you very much. For us, we regard it a bit as the golden standard. If we go as far as a bronchoscopy with lavage in a patient with bilateral pneumonia, which is in the pulmonary stage of the disease, and the PCR is negative, I think we conclude that COVID-19 is excluded. Okay, next presentation will be done by Professor Walter de Wever, one of our specialist thoracic radiologists, who will give I think a much anticipated lecture about the role of CT scan in diagnosis and perhaps differential diagnosis. Walter, I will let you adjust the screen.
Should go back. Thank you, Pascal, for the introduction. Good evening, everyone. So the topic of my presentation is indeed imaging and COVID-19. And in this presentation, I will tell you something about guidelines for imaging. I will show you some images, CT findings in this disease. I will tell you something about the CT reporting. And I will end with some initial results from in-home. And that's also the moment to go over to bronchoscopy. Since the outbreak of this disease in China, many papers are already published about this disease, also many papers about imaging. And this paper is a study that is often mentioned when we are talking about CT. It's a paper from a group from China, and this group would evaluate the value of CT in the diagnosis of COVID-19 with PCR testing as standard of reference. They included 1,014 patients in this study. All these patients underwent a CT and the PCR testing, and as a result, they found that 580 patients had a positive CT and a positive PCR testing. 105 patients had a negative PCR testing and a negative CT. Only 21 patients had a positive PCR and a negative CT. But what was important? It was important to see that 308 patients had a negative PCR test but a positive CT. And so they came to the results that the sensitivity of CT was very high, 97%. There was a low specificity. The positive predictive value was 65%. The negative predictive value was high, 83%, and the accuracy was 68%. So, based on these studies, guidelines were made, guidelines were proposed. You can find in the literature a lot of guidelines. I show you, or I propose you only these guidelines, the guidelines of the Belgian Radiological Society. And when we look to these guidelines, then we see that they say that the preferred imaging technique for COVID-19 is a low-dose chest CT. It is a pulmonary infection, and the roles or the rules for imaging in pulmonary infection are always the same. You start normally with a chest X-ray. But here in the situation, the first signs are ground glass opacities, and often you will not see these ground glass opacities on a chest X-ray. So when there's a discordance between what you see on chest X-ray and what you have in clinical situation, if there is a discordance, then you do a CT. Here, in this case, we do a low-dose CT. Another reason to do a CT is, of course, when you have complications. So here, the preferred imaging technique for diagnosing COVID-19 is a low-dose chest CT, but this CT should not be used as screening, not as a diagnostic test, but only as a triage instrument to decide where you need to send the patient to a COVID area or to a non-COVID area. So here you see the guidelines. When you, of course, have a general population asymptomatic, then you don't do any imaging. When you have patients coming to the emergency department with a clinical suspicion of COVID-19, but no need for hospitalization, then you don't do imaging. But when you have a patient with clinical suspicion of COVID-19 who need to be hospitalized, when you have a patient with an acute pathology who need urgent surgery, intubation, or maybe another therapy, or when you have a patient who will be hospitalized with high risk of infection, including patients with comorbidities, then you will do a CT, or you can consider to do a CT, a low-dose CT. And then when you have a hospitalized patient where you also can expect to have a COVID disease, at that moment you do imaging when there is a clinical deterioration. And in general, no follow-up imaging is done to determine the regression of the findings. So these were the guidelines of the Belgian Radiological Society. What are we doing in our hospital? So of course, when there is an asymptomatic general population, no imaging. Patients at the emergency with clinical suspicion of disease, but no need for hospitalization, no imaging. But when there is need for hospitalization, then we do the low-dose CT. And depending on the result, positive, negative, or indeterminate, together with the PCR testing, the clinician decide where the patient is sent. For the hospitalized patients who are suspect to have COVID disease, we do a low-dose CT, and then we as radiologists need to decide, is it a positive CT patient is immediately sent to the COVID-19 area, not back to his room, but immediately to the COVID-19 area. Is the CT negative, then patient is going back to the non-COVID area. Is the CT indeterminate, then the patient is sent to the transit area, and there the PCR testing, the result of the PCR testing is deciding where the patient is sent. What about now the CT findings? Here you see a table from this paper where a lot of findings are mentioned. But what's now important, what is very suggestive for COVID-19 disease, we see ground glass opacity in most of the patients. 86% of the patients are showing ground glass opacities, or we see consolidation, or we see a mixed pattern of ground glass opacity and consolidation. Where do we see it? In most of the time in the lower areas of the lungs. However, there is no really a craniocaudal distribution, but we see it in the lower areas. We see it in the peripheral part of the lungs, not really in the central parts, but in the peripheral parts. And it is bilateral, it is multilobar in distribution. So these are the most typical findings. So here a few examples. This was a 57-year-old man with cough and fever, a dry cough and fever. And what we see is these ground glass opacities in the periphery of the lungs. Another patient, a 42-year-old man with fever, dyspnea and diarrhea. And also here we have the typical findings of ground glass opacities in the basal parts of the lung and in the periphery of the lung. So these are the very typical findings. This is another patient, a 62-year-old man with cough and fever. And here we see also ground glass opacity, but this is some more nodular. And this is also described, nodular opacities. These are not the dense small nodules that we expect, but no, nodular ground glass opacities. And we see it also in both lungs, so bilateral and multilobar. And this is another typical presentation, or described as typical presentation, 81-year-old woman with fever. The first PCR test was negative, and at that moment the CT was done, and what we see are these findings. Here we see the reversed halo sign. What we see is ground glass opacity surrounded by an area of consolidation. Also here we can see it, an area of consolidation surrounding this ground glass opacity, and we see it especially in the periphery of the lung. So also this sign was described as typical for COVID-19 disease. What now for the CT reporting? Also here you can find multiple proposals in multiple papers. Here you have an example from the Dutch Radiological Society. This is an example from the Iron Radiological Consultant Group. And as you look here at the proposal of the Dutch Radiological Society, then they propose to conclude the report with these different cohorts. So where they say something about the level of suspicion. So when there is no suspicion, this means that there is that the CT is normal, or that there are non-infectious abnormalities, or it is a low suspicion, meaning that there are abnormalities consistent with infectious other than COVID-19, or it is indeterminate, which means that it is unclear whether COVID-19 is present, or it is high suspicion, abnormality suspicious for COVID-19, or it is very high, typical for COVID-19. However, in clinical practice, this is very difficult to make a distinction between all these grades. You need to take also in mind that you have a low dose CT without intravenous contrast in patients who are ill, dyspneic, so often there are also some respiratory motion artifacts. This is another example on how you can do it, and this is a little bit on how we are doing it in our daily practice. You can describe the typical findings, the ground glass opacities, the distribution, multilobar, peripheral, round opacities, maybe later, in a later situation, the linear opacities, the crazy paving or the reversed halo sign, and also signs who are inconsistent with this disease. Tree in bed opacities, centrilobular distribution, peribronchosvascular distribution, lymphadenopathies, pleural effusion. And then we come to a conclusion, and this is our conclusion of our standard protocol. So the question is there COVID disease? Yes or no? So it can be positive. We have signs very suggestive for COVID-19 pulmonary infection, or it is negative, inconsistent with COVID-19 pulmonary infection, meaning that there are no abnormalities, or maybe the presence of inconsistent findings, or maybe other abnormalities, or it is indeterminate. Then we have findings suggestive for the disease, but also findings who are inconsistent with that disease. A few examples. So this was a patient, 67-year-old man, dyspnea, cough, no fever, with a PCR positive, and it was a positive scan. We have again these ground glass opacities, these cobweb-like distribution of the ground glass opacities. So very suggestive, and this is positive. Patient died 7 days after this CT. Another example, also here, nodular ground glass opacity, maybe here with a reversed halo sign in multiple lobes in both lungs. Also this is suggestive. Also here in this patient the PCR was positive. This is a negative scan. What we see here in this 60-year-old man with dyspnea, we see only in the left lower lobe this consolidation, but it starts in the center part and it starts like a mass. So this is probably a tumor that we have detected here with the retroobstructive consolidation. However, this is without intravenous contrast, so we cannot say anything more. Here, another CT is proposed to do afterwards a CT with intravenous contrast. And this is a patient, 80-year-old woman, fever, dyspnea, PCR was 2 times negative, and the CT is from 23 of March, and what we see is ground glass opacities in both lungs, but more pronounced in the upper areas, not in the lower areas, and more pronounced in the central part of the lungs and not in the periphery. So this is inconsistent with COVID disease. And what we see also is this pleural effusion. So we have findings, ground glass opacities, which can be suggestive in patients with fever, dyspnea, but the distribution is not suggestive, the pleural effusion is not suggestive, so this is indeterminate. And 3 days later, so what we thought is it was more a pulmonary edema, and 3 days later, this is a CT of the abdomen, we have a few slices through the lungs, we see that all the findings are disappeared in the lung. What can we do more? Maybe we can give a score for the severity of what we see in the lungs. However, this is optional. What we can do is we can score every lobe based on a 6-point scale going from 0 to 5, depending on the amount of findings that we see. And so in total, we have a score on 25. It can give the clinician maybe more information about how severe the disease is. However, these scores are not validated, and it is a very time-consuming process. Maybe later with artificial intelligence, it can be faster, but this is something what we don't do in our hospital, and I didn't get the question from the clinician to do that for the moment. What about the evolution and the follow-up? This is a paper about the temporal changes of the CT findings in patients with COVID and pneumonia. And what can we read here is that the extent of the CT abnormalities progressed rapidly after the onset of the symptoms, with a peak in between days 6 and 11. What do we see? We see most of the time ground glass opacities, and then between days 12 and 17, we see a more mixed pattern, ground glass opacities and consolidation. And maybe what's also important in this study is that when the patient is discharged from the hospital, 94% of the patient will still show findings, ground glass opacities on the final CT scans. So what do we see? Initially, we don't see too much, somewhat ground glass opacity, but then we see that the ground glass opacities are increasing. Then between day 12 and day 17, we see more consolidation or more mixed pattern, and then later this pattern are decreasing, and we see more and more ground glass opacity again. What kind of ground glass opacity? It can be pure ground glass opacity, but then you can see here from day 5 till day 17, you see also lines, the typical crazy paving pattern, and that's decreasing again. But this is for me very important here. The lines that we see are very irregular lines, and this means irregular lines means that there is maybe some fibrosis. So maybe we can see also some secular lesions in the lungs after some time. How long? I don't know. An example, this is a patient, day 3, we see the ground glass opacity, also the crazy paving pattern. On day 7, there is an increasing of the findings, also on the left side. Day 12, a decrease of the mixture pattern, and on day 17, the ground glass opacities were almost disappeared. We don't do follow-up in our study, in our hospital, only here, this patient, where we see the ground glass opacity, a very typical finding in a patient with cough, dyspnea, and fever. CT on 22 of March. A few days later, it was increased, the dyspnea was increasing. They suspect some pulmonary emboli. Indeed, there were some filling defects, but you see that the ground glass opacities are now consolidation, so a typical evaluation. And here you see that at the end, when the patient is discharged, we see only ground glass opacities. And then to end my presentation, a few results from our hospital. We started with the first COVID scan on March 15, and now on April 7, we have already done 687 patients. And when we look at the first 200 CTs, then we see that 33 were positive, 48% were negative, and 80% were indeterminate. And when we look at the PCR test of this patient, then we see that 31% was positive and 68% was negative. For these indeterminate patients, then we see that 10 patients had a positive PCR, 27 had a negative PCR. But we see also, or we know all now, that these PCR testing became positive afterwards. And I think that this is the moment to go over to bronchoscopy, because these patients are most of the time sent to the pulmonologist to do a bronchoscopy. But for the conclusion, I can say here that CT is done, that a low-dose CT is done not as a first-line examination technique, but as a triage examination technique. And together with the clinical information, we can decide to send the patient to a COVID or a non-COVID area. Low-dose CT give earlier and faster results than PCR, and with a higher sensitivity, but with a low specificity. So I thank you for your attention, and I give the floor now to Professor Dooms for the role of the bronchoscopy. Wait. So. This is now.
Thank you, Walter. So, good evening, ladies and gentlemen. It's my pleasure to discuss the role for bronchoscopy during the COVID-19 pandemic. Is there a role? That's the question. So I will start with one slide on, and it's in fact the only evidence which there is, the data on the bowel fluid specimens reported. There is one letter in Lancet in 2020 mentioning on 15 samples that the positive PCR rate is 93%, and there is one publication in an online platform focusing on 20 samples they obtained in the second and the third week, which is logic, looking at the hospital admission, which is also between 80% and 100%. So that's the evidence, nothing else. That's one aspect. The other aspect is the statement launched by the American Association, which says that in patients suspected or confirmed COVID-19 infection, bronchoscopy is relatively contraindicated. In fact, bronchoscopy should not be done to rule in COVID-19 infection, given the risk of transmission to the healthcare worker, nurse, physician, but also to the risk for the patient, clinical deterioration shortly after bronchoscopy leading towards intubation. And that's in fact the sentence which is referred to by most of the physicians, that bronchoscopy is relatively contraindicated in this patient group. But we have to consider a role for bronchoscopy. In fact, when less invasive testing, PCR and or CT, are inconclusive, you should and you can consider an alternative diagnosis which might impact on clinical management. And this is certainly the case in patients who are immunocompromised, for instance, transplant patients or COPD patients on high doses of corticosteroids, or cancer patients getting high doses of corticosteroids, because the clinical picture of a pneumonia, viral pneumonia, which is non-COVID, might be the same. The same for pneumocystis. So with these aspects, we had a look at our own database. So the database already has been alluded to by Walter. And I put it opposite to the database from Wuhan. And as a physician, as a pulmonologist, looking at test characteristics, I really am interested in prevalence of disease. And if you look into the data, in China, the report on CT, prevalence of COVID-19 infection was 80 to 85% of the patients. While in our series, and these are the analysis of the first 190 patients who underwent both a low-dose CT and a PCR, the prevalence of COVID-19 infection was or is around, assumed, more or less calculated, 40 to 45%. Looking to PCR, positivity rate, 33%, CT findings very suggestive, so concluding positive and used as a triage method, sent to the COVID unit, it's 34%. But of those patients, 34% of all the patients we saw, 9% had a negative PCR test result. In the beginning, we have sent them directly to the COVID unit, but some of the physicians over there, they said, be aware, we are getting patients who are immunocompromised, transplant patients, bone marrow transplant patients, kidney transplant patients, lung transplant patients. Are you really sure this is COVID-19 infection? Second, some of the CT findings are inconsistent, meaning stream blood, lobar pneumonia, maybe pulmonary edema, and a negative PCR. Prevalence in our cohort is 46%. So these patients, they do not bronchoscopy, it's just routine clinical management. If it's stream blood, lobar pneumonia, you start them on empiric antibiotics. And at a later phase, when it's getting worse, a couple of days later on, you might consider bronchoscopy, but not in the emergency room setting. And then the third group, which was not considered in the Chinese publication, so in Belgium, in Leuven, we have the indeterminate group, so it's suggestive findings on CT scan, for instance, ground glass, but also other inconclusive findings, for instance, stream blood. This is considered indeterminate, and this was 18% of the entire patient cohort. And of the 18%, in fact, 11% of the entire cohort had a negative PCR. And these are the patients we discuss case by case with the physicians at the COVID maybe unit. And since we made some observations, I will comment later on. The patients who are directly sent based on a positive CT finding, very suggestive, but transplant patients, they were not sent directly to the maybe, or aren't sent directly to the maybe unit, to the COVID unit. They are sent back to the maybe unit in order to discuss case by case whether there is an indication for bronchoscopy. And this is in fact the database we have so far. So these are the data from 21st of March till the 4th of April, so 2 weeks, where we performed 28 patients a bronchoscopy after a negative swab result, but a CT scan which is indeterminate or suggestive in a transplant patient. And who do we perform bronchoscopy on? One important remark is the patient has to be stable, has to be able to and tolerate to undergo a bronchoscopy, taking into account this oxygen saturation, at least 93%, and the patient can be on additional oxygen, nasal cannula, which is less than 5 liter oxygen per minute. And how do we do it? Small aliquots, maximum 10 to 20 milliliter of saline to obtain 2 to 3 milliliter of lavage fluid, which is enough to do all the PCR testing. And of course, we do it in a secured endoscopy room with full personal protective equipment. Let's have a look at the results of these 28 patients. In 18%, 5 patients, the diagnosis of SARS-CoV-19 was confirmed by PCR on the bowel fluid. In 60%, it was only COVID-19 which was observed in these 5 patients. In 40%, there was also bacterial co-infection. So 18% came back COVID-19 positive, but 82% were negative. And in the majority of these patients, 70%, there was another diagnosis which really changed further management. And in fact, as I said, we are looking mainly at immunocompromised patients. And the viruses and fungi or bacteria we observed are mentioned in the list. Let's have a look at some clinical cases. Female, 67 years old. She's known with lupus. She is for years on hydroxychloroquine treatment, and since 1 week she had upper respiratory tract symptoms, and since 3 days fever of more than 38 degrees. Swab was negative, and on CT scan we see one isolated peripheral nodular ground glass with crazy paving pattern, which is suggestive, but it's also inconsistent because it's only one lesion, so it's not bilateral, it's unilateral. It's in the upper lobe. So these are inconsistent findings in terms of distribution. So we decided to perform a bronchoscopy in this patient, and in fact, the patient, the result came back as COVID-19 positive in this specific case. A second case, a male of 75 years old, since 3 days dry cough, fever 38 degrees, and now upon admission, short of breath. The swab came back negative. The CT scan shows us some suggestive findings, the peripheral ground glass, but also inconsistent findings. Bronchial wall thickening, and also bronchial wall thickening and peribronchial infiltration towards the center. So this is a very atypical distribution for COVID-19. But it's a mixture, so it's indeterminate, the CT scan. So we decided to perform a bronchoscopy, and the patient, in fact, had a classical bacterial infection, Streptococcus pneumoniae. A patient, 67 years old, it's a bone marrow transplant patient, coughing for 1 to 2 months, but now presented at the emergency room with increased shortness of breath and dry cough. Swab was negative. CT scan shows us suggestive findings, peripheral, bilateral, ground glass opacities, but inconsistent distribution, upper lobes and also towards the center. So we decided in this transplant patient to perform a bronchoscopy. And the bronchoscopy gave us a change in management strategy, was positive for pneumocystis, and was treated for this pneumocystis pneumonia. Another patient, 67 years old, again a transplant patient, this case a lung transplant patient, short of breath for 2 days, but already weaker since 4 days, and presenting with fever. Swab negative, suggestive findings such as peripheral ground glass, but also inconsistent findings, which is going towards the center, and also tree and bud and peripheral consolidation. We decided to do the bronchoscopy, and in this patient, in fact, there were not really specific findings, but the patient was treated with antibiotics and improved. But COVID-19 negative, so sent to the regular ward. Another patient, female, 53 years old, again a transplant patient, bone marrow transplant, coughing since 1 week, fever and shortness of breath. Swab negative, suggestive findings, peripheral ground glass, bilateral, mainly the lower lobes, but inconsistent given the fact that it's also going towards the hilum, and the upper lobes are involved as well. And there is also the pleural fluid at the right lung. So bronchoscopy was performed, again a picture of pneumocystis pneumonia, and negative for COVID-19. So I discussed with you some cases, typically the indeterminate cases with suggestive findings, but also with inconsistent findings, and the focus of your attention should be the immunocompromised patient. There is clearly a role for bronchoscopy. The ones with inconsistent features, tree and bud, lobar pneumonia, or pulmonary edema, there is no place for bronchoscopy, but empirical treatment of the bacterial infection or of the edema. And then you have I call it the lung cancer screening avant la lettre. So we are sending all the patients to low-dose CT. And in fact, besides COVID positivity, you might identify other lesions, for instance, a tumor, a mass. And there the timing of the bronchoscopy has been clearly stated in this British Thoracic Society recommendation. Treat patient for COVID-19 infection, and after 4 weeks to 6 weeks, you can consider the patient for a bronchoscopic procedure for a workup of this malignancy. So in order to conclude, is there a role for bronchoscopy during COVID-19 pandemic? Well, this should not be done to rule in COVID-19 infection. It could be considered in COVID maybe patients when CT scan and swab are indeterminate or inconclusive, and really think about an alternative diagnosis in the immunocompromised patient. But be aware of the patient. The patient should be stable, should be able to tolerate a diagnostic bronchoscopy. So I thank you for attention, and I will give the last word to this gentleman in order to end my talk. Thank you.
Okay, I would like to thank Professor De Wever, Professor Dom for these very clear and very nicely illustrated presentations. I think the role of CT scanning as a sort of gatekeeper or a means for triage the patients, and also the correct indication for bronchoscopy is very important for all people caring for COVID-19 patients, and especially for us pulmonologists. And I think with these presentations we got a lot of data which can direct us to which way to proceed. So now we switch to the second part of the symposium, the part on management of disease, and I will first give the word to Professor De Munter and Professor Vos, who will talk with us about the different antiviral strategies.
So, good evening. We now heard very well how to diagnose COVID-19, but now is the main question, of course, what to do with these patients. What do we have to offer them as far as treatment is concerned? And when we talked about this presentation, we heard already that this actually is going to be the shortest presentation of all, which means that that's not so good news. I'm going to talk mainly about antiviral treatment, although I will address also from time to time immunological treatments. I'm not an expert in immunological treatments, but these treatments are definitely important for COVID, although the place of these treatments has not been defined until now. Now, you all know this, and this is a bit of repetition, I know, but it's important to realize. So we have, and I see that actually the pointer does not work, and this has been like that since the beginning. So on top, we have actually a group of patients that are asymptomatic, actually don't develop any symptom, or a significant group of people that are polysymptomatic and that only have signs of an upper respiratory tract infection or a viral syndrome. And this may actually present with runny nose or sore throat, a bit of a dry cough, so mild disease. And then we have a group of people that eventually will go on to develop dyspnea, pneumonia, ARDS, and of course, some of the lesser frequent presentations of COVID-19. It's important to realize that the polysymptomatic patients are the most frequent ones. And we know from situations where testing has been done much more extensive than in Belgium, that probably over 10 times more people than are diagnosed with the tests have COVID disease and never develop severe disease. While actually then the group of the severe disease is, if you consider the total amount of patients that actually catch the virus, is rare. There is a time dimension. That means the upper respiratory tract infections and the viral syndrome, they mostly are in the beginning, and you actually, patients that go on to develop severe disease, they mostly have a history of 7 to even 10 days of mild to moderate disease. This has been explained also extensively. The place of testing, we've had 2 presentations about it, actually 3 if we include the bronchoscopy, but it's very important to realize that the virus in the beginning mostly is in the upper respiratory tract virus. These coronavirus are typically upper respiratory tract infections. And that makes that the sensitivity of the PCR probably initially is very, very high. We know that some asymptomatic patients, before becoming symptomatic, they already have virus in the nasopharynx and the oropharynx, and that at the later stage of the disease, the virus becomes less detectable in the upper respiratory tract and may actually be not even detectable in the lower respiratory tract at that time if we're talking about immunopathological presentations that are not directly linked to viral replication at that time anymore. So to summarize that, combined with the immunopathology, you have actually an upper respiratory tract infection, an initial disease that's mainly viral replication in the upper respiratory tract. And then you end, in the severe cases, with a picture or a clinical picture that's probably mainly determined by immune pathology, and in which we don't know very well how much viral replication is still present. And I think that summarizes very well also why we have this evolution from PCR positivity, and we have patients that are CT positive but PCR negative at that time. Now it's clear that if you have viral replication, the answer to, as far as treatment is concerned, is the use of antivirals. If you have immune pathology, the answer is immune modulation, and antivirals are probably not going to do much in that case. Now, if we look at that, we can also look at the place of treatments or the timings of treatments. We have 4 kinds of treatments in this case. There is a possibility of what we call pre-exposure prophylaxis, and that means actually somebody who has a high risk of exposure but has not been exposed yet, we put him on treatment to prevent infection. There exists something like post-exposure prophylaxis, and post-exposure prophylaxis, that's when we give treatment to somebody who has been exposed but is not having disease yet to prevent disease. Then we have patients who have mild disease, and in that case, it still seems quite logical to use antivirals in treatment, and there may already be a place for immune modulation, although we don't know that. We don't know that for the moment at all. And then if you have treatment of severe disease, we actually don't know at all what is the best approach. There might still be a factor, viral replication or triggering of viral infection of this immune response that's active, and then of course antivirals might still work. Or you might actually just have a completely derailed immune response in which it's important to modulate the immune system. Now, the pathophysiology of COVID-19 is determined by 2 elements. On one side, the viral replication, and that means actually that we have a virus. This virus connects to the ACE2 receptor, will then get into the cell, will use its RNA-dependent RNA polymerase, which is the most important viral enzyme as a target for treatment, and then will use the system of the host cell to produce new variants. And of course, with antivirals, we can work on this. On the other side, you have the immune pathology, which is, like always, an immune reaction determined by antigen presentation, cellular immunity, humoral immunity, and which, in its most pathologic way, results in a cytokine storm, in which, among others, interleukin-1 and interleukin-6 are important mediators. These are the severe forms of the disease. We also now know meanwhile, and I know that this is very small, but we know also how the connection or how the use of the virus of this ACE2 receptor triggers the kallikrein bradykinin system, and actually because of that way will cause vasodilatation, vascular permeability, complement activation, local inflammation, fibrin deposition, and diffuse intravascular coagulation. And these are actually the reasons why recently it has been published again, or it has been published in New England, that actually it's also a prothrombotic disease that may cause pulmonary embolism or thrombosis, peripheral thrombosis. So when we look at this immune damage, we will also have options to treat this. I will not so much go into this. I will mainly concentrate on antiviral treatment. What drugs do we have then? The first drug is chloroquine and hydroxychloroquine. Chloroquine is an old drug, an old antimalarial, known under the commercial name before Nivaquine. It's no longer available in Belgium, so we cannot use it. Hydroxychloroquine, which is Plaquenil under the commercial name, is a drug that's been used for a long time in rheumatic diseases and is still on the market in Belgium. These drugs have known anti-inflammatory effects, and in vitro antiviral effects have been demonstrated, although it's clearly not typically antiviral drugs. When you treat COVID-19 with these drugs, you need higher doses than you use for rheumatic diseases. And it's clear that hydroxychloroquine, for the moment, is the only drug in the Cienzano treatment guideline for mild, moderate, and severe disease. Why do we use this drug, or what is the evidence for using this drug? this evidence is extremely limited. There is one small Chinese randomized controlled trial, which is actually a preprint, so it's not been peer-reviewed, it's somewhere on a preprint server. 62 patients randomized 1-to-1 to either hydroxychloroquine or standard of care. And what did that result in? Actually, the group with hydroxychloroquine had a clinical recovery that was 1 day faster than the standard of care. There was less progression to severe disease in the hydroxychloroquine group, and there was the chest CT improved more in the hydroxychloroquine group than in the standard of care group. Not really impressive findings. Then we have one open label controlled trial, which is actually peer-reviewed and is available through PubMed at this time. 36 patients, 26 patients treated with hydroxychloroquine sulfate, but 6 of these went lost to follow-up, were actually not followed up. And of the 26 patients, 6 were also treated by azithromycin. Maybe Robin will mention this also when he talks later on about azithromycin. There was also a convenience control group. These were not correctly balanced with the patients. They were just used from another hospital and people that were not treated with hydroxychloroquine. And then when they looked at the results, they saw that the virological clearance at day 6 was 70% in the hydroxychloroquine group versus 12% in the control group. With the graphic just below, you see in red the hydroxychloroquine group. This looks impressive, but it's a very small study, and there are significant problems with the methodology of this study. So not really impressive as the basis for the use of the most important drug in our national guidelines. Second drug is remdesivir. Remdesivir is a drug that was developed for Ebola, but which failed in an Ebola randomized controlled trial. So it performed less well than monoclonal antibodies in Ebola disease. It's a direct antiviral, and it targets this viral RNA-dependent RNA polymerase. In vitro active, it's active against SARS coronavirus 2, and it's a potent drug. There is only an IV formulation. The drug is not yet commercialized, and there have been programs for compassionate use access, which in UZ Leuven have been used in the beginning. I think 2 cases we had. And there is now limited availability through expanded access programs, in which UZ Leuven will also have some access. There is very limited data on side effects from this Ebola study, but this data suggests that this tolerance of this drug is quite good. And the use of this drug is mentioned in the Cienzano treatment guideline, but it's clear that actually they know that the drug is not very well accessible, so they cannot really recommend use in specific situations. What's the evidence? Cases published reporting successful treatment. There is no clinical trials published, but there in China, 2 trials have been performed with remdesivir, one in severe patients and one in mild to moderate patients. The results of these trials are awaited this month, and it will be very interesting to see whether the drug has an effect, whether the side effect profile remains favorable, and whether there is an effect in early disease or in late disease also. Third drug, favipiravir. This is, again, a direct antiviral. It targets the viral RNA-dependent RNA polymerase again. So again, the same enzyme. This is a drug that's registered in Japan for influenza and has been extensively used in Japan for influenza. It's theoretically potent against SARS coronavirus 2, and it also, as an influenza drug, has a relatively low toxicity. What is the evidence for this drug? Again, a preprint publication, so not peer-reviewed yet. Study performed in China, a randomized controlled trial, in which they randomized 240 patients 1-to-1 to either favipiravir or Arbidol. And Arbidol is a drug we don't know here, but which is used in China and Russia for the treatment of influenza. We don't know very well what's the side effect profile of this drug or what's the effectivity of this drug in influenza or in COVID. They looked at clinical recovery, and overall in the favipiravir group, clinical recovery was 61% versus 51% in the Arbidol group, and this was not clinically significant. And then they looked afterwards in a subgroup of the non-critical patients without comorbidity, and there they had 71% versus 56%, which was statistically significant. So actually in the group which probably is least important to have a treatment effect, because these were non-critical patients, the drug seemed to perform better than the Arbidol. They also looked at side effects, and the only significant difference was that in the favipiravir group, there was an increased uric acid. So again, a drug with very few evidence for activity. These first three drugs were all repurposed drugs. These were never drugs developed for coronavirus specifically, and they were used because it's clear that with an epidemic that's going on for 3 months and a virus that we know since 3 months, that there are no specifically developed drugs for this virus at this time, and that it will take quite a while before we have specifically developed drugs. In China, they also looked at another drug which had been suggested to have some activity against SARS, the first SARS-CoV-2. They looked at lopinavir-ritonavir, which is an HIV drug, which is no longer used much in HIV. And actually, this was the best clinical trial that has been published until now on drug treatment in COVID. And actually, in this study, there was no evidence of effect in this study. Some people said, yes, but you cannot see effect because were mainly severe patients, but they also did not see any effect on viral load, which indicates that for an antiviral drug, probably this drug will not have any effect, and we are in Leuven not even considering using this drug anymore. On azithromycin, I will not talk because Robin will address that. A non-antiviral drug, but a treatment modality with antiviral activity is reconvalescent plasma. Actually, if you take plasma from patients that have survived COVID and that have immunity, you could actually try to use this in patients that have active disease. This has not been proven, and there is a plan to have a large study in Belgium and in other European countries to use this as a treatment modality. Then the last element, immunological treatments. I'm going to be quite brief. Corticosteroids, there is no evidence for use specifically in COVID, at least not in general. There is evidence against use in the more severe coronavirus infections, MERS and SARS. Maybe there is a place for corticosteroids in ARDS or non-responding ARDS in the beginning. I will leave that to Philippe to comment on that, if he has comments on that. And then if we look at specific drugs targeting cytokines, then we have anakinra, which is an anti-interleukin-1, and tocilizumab, which is an anti-interleukin-6. These drugs have been used in cases of COVID, but actually there are no trials that prove evidence. Conclusion, currently no convincing evidence of beneficial effects of any drug on outcome of COVID-19, but science rapidly evolving. Rare or expensive drugs may not be accessible if proven effective, and that's important to realize. Every time a drug is mentioned in literature or in a symposium, what you see in the next days is that the stocks of the drugs are quickly exhausted because everybody starts stockpiling this drug or using this drug in compassionate use settings or in non-study controlled settings. The question, as I told you, may not only be which drug, but which drugs at which stage. Antivirals probably more place early, immune modulation probably more place at the end. We have national guidelines written by our colleagues in Antwerp and CSU Saint-Pierre on the Cienzano website. I would like to finish saying that for now, do not feel guilty not prescribing a drug, especially if you have patients with contraindications, with side effects, or no access to drug, because the balance benefit-harm for any of the drugs has not been settled, so we don't know whether we're doing something good or bad when prescribing these drugs. To end, 2 slides on studies in Belgium, and I know that I will be far from complete in these slides. I would like to thank Professor Bart Lambrecht, who sent me a slide on his 2 studies that he's performing from UZ Gent in multicentric studies. The SARPAC study is a randomized study with inhaled recombinant granulocyte macrophage colony stimulating factor versus standards of care, mainly for patients at risk for progressive COVID-19. And then the COV-8 trial is a randomized trial of anti-interleukin-6 and or anti-interleukin 1 versus standard of care in patients with active cytokine storm. So if you want information on these studies, please contact Professor Bart Lambrecht. Another multi-center trial is the Solidarity trial. This is a WHO platform developed, a very large study that has an adaptive design, so may actually include other arms in the future, but which compared standard of care with remdesivir or lopinavir and ritonavir, or lopinavir, ritonavir and interferon beta, or hydroxychloroquine. So if you want information on this study, contact Professor Goossens. And then when we talk from Leuven, we have the DOWN trial, which is actually a series of trials, a fast-track system going from the lab in the Reha Institute, where Professor Johan Nijts, he has a large series of compound seed tests to see the activity against the SARS coronavirus 2. And the hits of these studies will go to the clinic, immediately to clinical trials. We had a first study that started already and that has included until now 60 patients with itraconazole, randomized versus standard of care, currently a monocentric study. And then there is the Down Azitro study, for which Robin will address. And of course, all of us are very busy with developing other studies. Our main problem currently is finding enough patients to do all these studies in, and finding enough finances to be able to pay for all these studies. So I will leave now to Robin after disinfecting my working area.
Thank you, Paul. Good evening, ladies and gentlemen, at home or more likely in these days at work, like we are. I will talk about azithromycin in COVID-19, and as some of you may have heard, there's been a lot of fuss about azithromycin nowadays. And if you just do a quick Google, you can find anything you want. You can find proposals for big trials in the States. You can find warnings on the other side of the globe about the possible side effects of these drugs or drug combinations. You can even find national guidance. If you look at the BCFI, it says that you shouldn't prescribe azithromycin for the home treatment of COVID patients. And then you've got the NHS, which just yesterday sent out a small statement about whether perhaps azithromycin could even be used as pre-exposure prophylaxis in healthcare workers. So why azithromycin? Well, we as pulmonologists, most of us know that azithromycin is actually a fantastic molecule. It's a macrolide, and we've been using it for more than a decade. And this slide basically summarizes the properties of this molecule. It has proven anti-inflammatory and immunomodulatory properties, and this is in different structural cells like epithelial cells, endothelial cells, fibroblasts, and leukocytes, for instance. It is a strong inhibitor of protein synthesis, and proteins are, for instance, cytokines, like the ones which are involved in the cytokine storm in COVID, being IL-1 and IL-6, for instance. It also inhibits production of growth factors, acute phase proteins in the liver and hepatocytes, which produce CRP. It's also reduced. And of course, viral proteins are also affected by azithromycin. It changes the intercellular signal transduction cascade. So if there's a signal coming from the cell surface from a receptor which needs to go to the nucleus, and this is altered by azithromycin through the interactions with the MAP kinase pathway. It has been shown to inhibit the transcription process itself in the cell nucleus. It even alters gene expression in some cells, and in this way it alters the function of different cells. For instance, it improves neutrophil degranulation, it improves macrophage and neutrophil phagocytosis, it improves apoptosis in some cells. It even shifts the balance from a pro-inflammatory Th1 profile to a more anti-inflammatory Th2 profile. It has even some antiviral direct or indirect effects. Direct effects are probably due to the fact that it accumulates very, very strongly in the lysosomes, in the structural cells and in the leukocytes. changing the interlysosomic pH. This is probably also the way in which hydroxychloroquine works. This affects intercellular trafficking of the lysosomes. I will show you this in a picture in an instant. And it alters the viral protein synthesis. Indirect effects are due to the fact that azithromycin improves or augments the host cellular interferon production. As you know, interferons are important cytokines which are produced by cells infected by viruses to try to defend them against the viruses and their neighboring cells. So these indirect effects actually cause a reduction of the viral load in infection. And by the way, we know that it has some antibacterial effects, of course, through, again, protein synthesis, inhibition of the bacterial ribosome proteins, and it also inhibits generation of other molecules, which are called quorum sensing molecules, which are providing crosstalk between bacteria, and it also affects the biofilm formation in several bacteria. So it has a very broad spectrum, and if you would look at it at the cellular level, you can see that all these stars here are the places where the azithromycin might work, and I've told you this may be very important for what's to come, the COVID disease. So you see it has a very broad effect in many cells. Furthermore, it has a very good pharmacokinetic and pharmacodynamic profile. It has good absorption after oral intake. It has a very rapid accumulation in the tissue. It reaches its maximum concentration within 2 to 4 hours after intake. It accumulates in the cells, and these traffic to the site of inflammation, and they're causing very high tissue concentrations, which are more than 20-fold higher than that in the plasma. And intracellular concentrations are more than 200 times higher than the extracellular concentrations. This also makes that azithromycin has a very long half-life, so you can find it after just one oral ingestion of, for instance, 500 milligrams. You can find it for up to 60 hours in your system. One advantage is that it does not induce interaction with the CYPs, so drug interactions are very rare, and the PK/PD profile is more or less unchanged in patients with mild to moderate hepatic impairment or renal insufficiency, which is, of course, an advantage in many of our patients. It's proven to be quite safe. There were some issues about QT prolongation, but this is mainly in very old patients with heart disease, an issue. In other patients, it's rather not a big issue. Has been proven in many randomized trials. It may actually cause some hearing loss, which is reversible after stopping the drug. And of course, you have to be aware of allergy to macrolide. Now, how would this fit the COVID disease? Well, if you take the same slide of Professor de Munter and you would put the mode of action of azithromycin on this slide, you can see that it actually has the capability to attenuate the viral replication in the infected cells at different levels. And it has the possibility to attenuate the immune pathology affecting several cells of the innate and adaptive immune response. And this has actually been proven for many viruses, including influenza, RSV, and more rare viruses such as Zika virus, remember a couple of years ago, and Ebola virus also in these in vitro systems show that this is the way azithromycin works. So back to the clinic, what's the evidence? Well, there's very little evidence. There's the one trial from Marseille, already alluded to by Professor de Munter, which showed that azithromycin in, let's say, non-randomized way, showed some effects on virological cure, they called it, being PCR positive on swab, evolution between day 0 and day 6, as you can see in the graph. So we'll talk you through it. It's quite a busy graph. So the black line are, let's call it standard of care, treated patients from different hospitals, 4 different hospitals. And you can see, and let's look at day 6, that the majority of these patients were still positive, swab positive at day 6. And this may also explain the fact that we see prolonged viral shedding, for instance, in China, to up to 20 days. So this makes some sense. The blue line were the hydroxychloroquine treated patients, and you can see that the PCR was only positive in about half of the patients at day 6. One patient even got azithromycin a bit later and was cured shortly thereafter. And the green line are the azithromycin additional on top treated patients, and you can see that 0 patients at day 6 were swab positive, although if you read the letter very well, you can see that 1 patient was again positive at very low levels at day 8, so 2 days after this endpoint here. What are the facts, actually? I know there's a big fan of facts, but actually if you look at the slide, at the text, it's a non-randomized multi-center convenience sampling trial. PCR was perhaps not always performed in a standardized or uniform way. Actually, if you read the study protocol, it says that the study period was 14 days, but there are no results reported on the 14-day endpoint. Azithromycin was added to prevent bacterial superinfection, but there were no data on any bacteria or any other types of infection in the paper. And so, as I already said, endpoint at day 14 are not reported. Another thing that's quite strange is that the journal where it was published, the chief editor is actually a colleague of the main author of the paper, which may also perhaps explain why the paper was accepted, revised, and published within 4 days, which is, in academic terms, light speed. So the facts, this is actually the main author of this paper. Well, I'm not sure. There are some things that worry me when I look at this colleague's office. You see a small placket here above his head, which says, for those who know Latin, beware, because one's fall from grace can come swiftly. Maybe that's also the case here. And you can see another thing on the desk here, which for me looks very suspicious, and it looks like the list of the patients which were included in his trial. You know, always the paper on top of the pile is mostly the most important. So we'll see, time will tell, but meanwhile there will come some other evidence. For instance, this study from Paris, which tried to do the same, 11 consecutive patients hospitalized for COVID, treated in the same treatment schedule. 1 patient died, 2 were upgraded, and they showed that at day 6, so same endpoint, the majority of these patients were still positive for RNA on the swab, so a negative study. Let's broaden the scope. Macrolides in other coronaviruses, for instance MERS. There's one big study, retrospective analysis, multi-center cohort, which looked at 90-day mortality and at MERS clearance in more than 300 critically ill patients, of which 40% received macrolides, and the most prescribed macrolide was azithromycin. 70% was started at day 001 in the ICU in most cases, and they could show no reduction of the 90-day mortality or no difference in the MERS coronavirus clearance. There were some statistical issues. For the sake of time, I will not go into them, but if you would look at the data, actually, the table, you can see the macrolide group on the left and the no macrolide group on the right. And you can see that actually the macrolide group was sicker. They had more non-invasive ventilation, high frequency oscillation ventilation, more use of nitric oxide, more prone ventilation, more use of antivirals, intravenous immunoglobulins, renal replacement therapy. These are actually the things that you do when things go bad. They were longer in the ICU and they had more invasive ventilation. So in sicker patients, and then look at the outcomes, ICU mortality was 10% lower. Hospital mortality was 10% lower. 90-day mortality was not significantly different, but let's say trend 10% lower. Length of hospital stay was shorter, so at least these macrolide treated group were equal, being sicker. So perhaps this means better, I don't know. Back to our petri dishes. Other macrolides. What are the facts? Well, there is one study looking at tacrolimus, which is a macrolide immunosuppressant. We as transplant physicians know this very well. We give this to our transplant patients. It was tested in epithelial cell lines, virus cells, and it showed a very strong antiviral effect in these cells. Would this also be the same for azithromycin? Well, actually, we asked the question to Johan Nijts from our lab in the KU Leuven, and For reason of confidentiality, I can't show you the curves, but I can say that in the same range, actually, for the SARS-CoV-2, the azithromycin showed the same response to the virus replication. So this brought us to think, well, maybe we should do a trial, and we called it the azithromycin trial. Briefly, it's a randomized open-label trial, proof of concept, multi-center, 12 centers, the majority in Flanders, and will include adult patients with confirmed severe SARS, and we will randomize these patients in a 2-to-1 ratio to standard of care versus azithromycin versus standard of care, and looking at very relevant clinical endpoints. Also, secondary endpoints will be very relevant clinically from a lab point of view, from a safety cardiologic point of view, and we'll also look at the PCR, so viral replication. Other antiviral drugs in this setup will come, plasma, other things. So let's fight the virus from dusk till dawn, and let us end this horror movie. And perhaps that's also what they're doing in other studies worldwide, with azithromycin included. And you can see here more than 20 studies listed which are currently investigating azithromycin in this setting. Thank you.
Okay, so thank you very much, Professor De Munter, Professor Vos, for these very nice presentations. I think I have understood that the situation is very difficult. There are still a lot of unanswered questions, but I think that you provided us with enough data to digest for now. So for time concerns, we are running a bit much late. We will ask no questions, but we will switch to the second part of our management section, and this will be the management of COVID-19 patients on the intensive care units. And I'm very happy to be able to announce our new top doctor, Corona top doctor, Philip Meersman. He is now famous in whole of the country, and we are very happy that he found the time to give this presentation. Philip.
Thank you, Pascal, for this nice introduction. I would like to give you a hug now, but it's not allowed, I think, due to some kind of virus. I did see that you didn't clean the microphone, but don't worry, Natalie, I will try not to lick at it during my presentation. So I will tell you shortly something about the management of COVID-19 patients in ICU. I think I could talk about for five hours, but I only have 20 minutes, I think. As you may know, the pandemic started in China, and for this I thought it would be appropriate to start my talk with a famous Antwerp, well, slightly adapted Antwerp quote. Met alle Chinezen, maar toch ook een beetje met een dezen. But I had to do it in English, so I will tell it in English. With all the Chinese, but also a little bit with een dezen. Because we have to be honest, this is not the same virus as the flu, as they told us in the beginning of the pandemic. It's totally different. It has a huge physical and emotional impact to all of our caregivers, and also probably an enormous economical impact. Moreover, it gives a lot of pressure to our healthcare systems, and especially to our ICUs. I will give you some data about our critically ill COVID patients. These are, I have to say, these are really sick patients with high oxygen needs. So I only will show you the data of patients admitted to our intensive care unit who are ventilated or on Optiflow. These are data until last Monday, I think. So we admitted 58 critically ill COVID patients in our both ICUs, first in the medical ICU, and then we opened 2 and afterwards 1 extra intensive care unit. But as you can see, these 58 critically ill patients are around 20% of all patients hospitalized in UZ Leuven for COVID. And as you can see, only 11 patients were discharged at this moment. This just to show you that these patients will stay for a long time in your ICU for at least 2, 3 or more weeks. Most of the patients that were admitted to our ICU have one or more comorbidities, such as arterial hypertension and diabetes. And I cannot show you really now data on mortality because we didn't have a lot of patients for the moment, but in literature, the mortality in ICU is very high. The age distribution is well known. Most of the patients are between 50 and 80 years old. Most of them are male. So now we know that if male patients have a cold, they are really sick and they are not playing. What was remarkable is that most of our patients have a BMI of above 25, and half of the patients that were ventilated have a BMI of more than 30. There could be multiple reasons for that. They are more at risk to develop diabetes and arterial hypertension. They're probably more difficult to ventilate. And another potential explanation is that they have the also ACE2 receptor in adipose tissue cells, which could make them more vulnerable for more inflammatory reaction and severe illness. Most of our patients were admitted to our ICU on Optiflow, but as you can see, most of them will be eventually intubated and ventilated. And as you can see, we are almost half of our patients will receive prone ventilation during their stay in our ICU. A lot of patients receive vasopressors, but this is not because of shock, but because we need to use a lot of sedatives due to difficult ventilation, but not due to shock. And about 50% of our patients have kidney failure, which need renal replacement therapy. And all these figures and data are comparable with the data that are published in international literature. So you can see these are really severely ill patients with predominantly respiratory problems. So it's not like the flu, like the influenza we know, and also the disease course can be a bit different. Some patients have some symptoms for a couple of days and then deteriorate very fast with high need of oxygen, and these patients need to be intubated and mechanically ventilated very soon or immediately. And this is a bit like our influenza pneumonia admitted in our ICU. Some patients are less sick, have mild or moderate hypoxemia and can get better with only oxygen supply, low or high flow oxygen. And there seems to be also a group of patients that have a more indolent course that are admitted with low inflammation, but during their disease, the inflammation oxygen need is going up, and eventually they are admitted at our ICU. But what is remarkable is that almost all of our patients admitted to our ICU, mechanically ventilated or on Optiflow, have a biphasic course. They initially get better while they are ventilated. They get better, and then for some other reasons they have more inflammation, and the picture is back to the beginning, and we have to start everything all over again. And also in our biochemistry, we see this: the CRP is going up early in the disease and then going down very fast and then getting up for some reason again. And the same for the D-dimers, but with some delay. And the reason why is not clear, but these patients seem to be very vulnerable for events that can trigger inflammation. Maybe our ventilation could be a reason. Another difference compared with influenza and the classical ARDS ARDS is that they seem to have a more atypical ARDS, and some patients have a more have the classical typical ARDS features. But most of our patients have a normal or a high lung compliance and have a dysregulation of perfusion with low VQ matching. These are the patients with the ground glass opacities. Compared to the typical ARDS with more consolidations, low compliance, alveolar collapse, and a high right-left shunt. And another feature, what Paul already told us, is that this is not only a pro-inflammatory disease, but also a pro-thrombogenic disease, and there seems to be pulmonary microthrombosis who makes the disease even more complicated. And we know that the atypical ARDS forms can evolve to a more typical ARDS, probably later in the phase where the green curve is getting up. The possible pathophysiology is complex, and Paul and Robin showed you a slide, and I'm glad they did, because it's too difficult for me to explain and to understand. But if you want to read something, Van de Veerdonk from the Netherlands wrote a very nice paper where he explains the possible pathophysiology with the bradykinin and kallikrein. The ICU management of these patients, well, there are a lot of guidelines, but you have to know that these guidelines are based on the literature of the viral pneumonia, such as influenza and SARS and MERS, and the literature based on classical ARDS. But as I told you, this is not influenza and this is not a typical ARDS, so I think the guidelines will change with time when we have more information about these patients. Maybe an important question for the people at the ward is when to admit your patient to the ICU with COVID-19. Well, the first question you have to ask you is, should your patient be admitted to the ICU? And your hospital should make a flow chart together with the ethical committee where they have to look at possible comorbidities and take into account the resources you still have. Age is a difficult issue. I think, or we think, that frailty is more important to see if the patient will benefit ICU or not. And the clinical frailty scale is the one we use. A frailty score above 60 of 60 or above 60, then we suggest that these patients should not be admitted to the ICU, because the disease is a disease that will take very long before it gets cured. So these patients will not benefit from ICU, and always, of course, consult your ICU physician. Once you know you want to admit this patient to the ICU, the question is when. Well, I think it's very difficult because the symptoms can fluctuate very often. The hypoxemia is well tolerated, so I think a clinical evaluation is important. The evolution of the oxygen need, is it in a couple of hours or not, is very important. And some score that can help is the early warning score that was adapted for the COVID, where they added the age because they saw that an age above 65 is a high risk for complications. In the ICU management, the first thing to do is always protect your people, but I do not have time to go into detail, but this is the most important thing, in fact. So all these people will be hypoxic, so they will receive oxygen therapy. We will target to oxygen saturations around 90 till 94. I don't think they have to have saturations above this one. You try to give the oxygen with flow as low as possible. The oxygen need, as I told you, can fluctuate, so try to counteract fever, for example. And if you need higher flows to have a good saturation, I think it's the moment to contact the ICU care, because if there is enough capacity, high flow oxygen preferably should be given in an ICU setting. And what we can do is always try a high flow oxygen via nasal cannula, the OptiFlow. Preferably we start with low flow because there is always a fear for infection, for spreading of the virus. But if necessary, we give higher flows. Data on non-invasive ventilation is also taken on from the data from literature on ARDS, where it is not advised to do it unless it's for acute lung edema or in patients with COPD, because it has been shown that the mortality is higher in this group of patients, probably because of delay of intubation. And some people try OptiFlow and autoproning, where they ask the patient to lie on his belly, but we never did it. It's not well tolerated in the ICU. If it's not enough, the next step is intubation, and it's always difficult for us. What is the perfect timing? If you do it too early, you will use probably too much resources. If it's too late, there is a high risk of problems during the intubation. Some signs that could help is when you have a rapid progression, if there is a lack of improvement on high flow oxygenation, if patient becomes hypercapnic, and probably what could be important is just look at the patient and see if there is a high work of breathing, if there is excessive inspiratory effort, and if they are in the ICU, you can see clearly big swings on the central venous pressures, which could be a sign of high work of breathing, and this could be an important finding. Prickle stimulus. Thank you, Pascal. An important stimulus for inflammation, which could start the second phase in our patients. And always for intubation, use strict procedures to avoid spreading of the virus. I will not go into detail for the ventilation strategies. I think although it's a typical ARDS for the moment, I think we have to do the lung protective strategies as we do for every ARDS, but probably this could change when we have more data on the ventilation of the atypical ARDS. We see that we need a high level of sedation and intermittent neuromuscular blocking agents, but also there we will have a shortage, so we have to change every day almost our therapy strategies. There is no good evidence to use it. The best thing to do if you have problems is proning. We do it very early for several days, at least 12 to 16 hours. We coordinate it so that there is one group of nurses and doctors that prone everybody at the same moment, just to be not to use too much PPE. And as a last resort, it's ECMO, but we only had 6 ECMO for the moment. The weaning is a difficult part because we are afraid of this second phase, when we see that during the weaning patients are having a high driving pressures, high tidal volume. We know that this is pro-inflammatory and that the second phase could start. So I think we have to be patient and wait until inflammation is better and the patient is more awake to start weaning. Another important part is the procoagulant effect of SARS. We see that D-dimer levels are correlated with severity of disease and with strong viral-induced activation of the coagulation system. How it works is not really known, but we see in our ICU, and I think in several ICUs in Belgium, that we have a higher prevalence of thrombosis, DVT, clotting of the CVVH filters and ECMO oxygenators. There is some evidence that these patients are prothrombogenic, but these are retrospective data, and I think also that the effect of high PEEP and proning can have an effect on on this thrombogenic effect. So we made together with Peter Verhamme and Christophe van der Brille a suggestion to more anticoagulate these patients with enoxaparin with an intermediate doses, even if there's no signs of DVT, and we prefer to continue prophylaxis until recovery. We do not suggest to use oral anticoagulants because it's not well known how good it is taken in the GI tracts, because there also you can have infection with SARS. The other supportive measures are similar to ARDS for the moment, with some key point that these patients have high PEEP, so that the right ventricle is under stress and there is an impaired venous return, so patients can become hypotensive. 50% of the patients should do myocardial injury. For the moment, we did not see this problem as they saw in China. Shock is very rare. 50% of the patients need renal replacement therapy, where we have the problem with thrombosis of the CVVH. Nutrition, they receive the same nutrition, but a lot of patients have high residual gastric volume because of the high sedatives, the high dose sedatives they receive. We start antibiotics when they are admitted to our ICU, but we stop very early if there is no signs of surinfection, and we look very closely for thrombosis. As Paul told you already, there are other therapies, and the position during the disease course is not always clear. But I think this should be the one. And just one remark about steroids: it is, for the moment, it is suggested not to use it, but these data are from viral pneumonia, such as influenza, MERS, and SARS. We are afraid of opportunistic infection and also for the longer viral shedding, although there are some retrospective data from China, where they see that the mortality in those patients who received steroids were much lower. There are some new data on the use of dexamethasone in ARDS, low dose for a short period of time, but in these papers there were not many viral pneumonia included, so it's very difficult to say something about it. We consider to start low-dose steroids in the second phase of the disease, when we see that there is a high inflammation with high CRP, ferritin, and clinical worsening after exclusion of a new infection. So I think the treatment of these patients, it's very challenging, not only because of the disease, but also because of lack of capacity, lack of medication, lack of PPE, and so maybe sometimes lack of patients. Not patients, but patients, because these patients stay very long in your ICU, and this could be very challenging for the physicians. And what with life after the ICU, I think Natalie will tell us something about it. So I would like to conclude and thank everybody who's taking care for COVID patients, because it's not easy, and especially our young doctors, because they're always forgotten, I think, but they are really in the line of fire, and they do a fantastic job. And I am glad that I can work, so I'm not at home. Thank you.
Okay, thank you, Professor Meesman. I think you're still a young doctor too, but I'd like to thank you for your very nice presentation. I think covering all important topics of the ICU management of the COVID-19 patients. And now, before I give the talk, the stage to Natalie, who will give a talk about in the third section of our symposium about life after ICU, perhaps life after discharge from hospital with COVID-19. What will happen to the lungs? What will happen to the patient? Perhaps we don't know quite well, but Natalie will share some thought with us. But before you take the stage, I will, especially for you, the
Thank you, Pascal. Okay, good evening, everyone. It sounds a bit weird to talk about life after COVID-19 hospitalization in the heat of the fight. But anyway, within the next 10 minutes, and I do promise 10 minutes, I will try to convince you of the importance of following up patients with COVID-19 pneumonia. So a brief outline of the context, as I think you all know by now, but I'll quickly walk through it. The main presentation of SARS-CoV-2 is a viral pneumonia. Severe disease presents in only 20%, of which 5% of patients will end up at ITU. The elderly, unfortunately, they bear the brunt, but it's not just the elderly. From the Cienzano data that you can see at the bottom of the page, at the slide, sorry, you see that COVID does affect a broader range of age, and from the CDC COVID response task force, a recent publication showed that 55% of hospital admissions and 47% of ICU admissions are less than 65 years of age. A lot of patients really develop respiratory distress and even respiratory failure, as Philip already mentioned, requiring prolonged supplemental oxygen and protracted mechanical ventilation, with reflecting in long hospital stays. Now, we're about 4 weeks in the epidemic in Belgium, and the first patients were being discharged from the ward, first patients with severe disease, such as this chap, of which you can see the CT projected, 33-year-old male with no underlying comorbidity, but who required supplemental oxygen for 12 days and had a really nasty CT scan. So that started to raise some questions as to what proportion of these patients admitted to hospital or returning from ICU and then eventually going home, what proportion will have persistent respiratory symptoms, and for how long? Are these complaints, are they due to pulmonary or cardiac function deficits? Will the radiological resolution, will it be obtained eventually? And by what time point? And what is the physical, but also functional, emotional, social impact of hospital admission on COVID-19 survivors in the short and the longer term? Now, I have to tell you that follow-up data on the SARS-CoV-2 are still very scarce. Actually, I've found two publications, mainly on radiological findings, both from China, with one is a retrospective study of 17 discharged patients that have been followed up for about a month. The other one is one that Walter already referred to as well, is a prospective longitudinal evaluation of CT findings in 90 patients with COVID pneumonia. And what we already heard is that indeed there is a radiological evolution over time in SARS-CoV-2. We're starting with often focal ground glass opacities in the beginning of the disease, rapidly evolving during the second week into bilateral, multifocal, peripheral ground glass opacities mainly. But then in the week 2, week 3, consolidation is coming more to the foreground, and even some small pleural effusion air bronchograms may develop over time. And this figure you've also already seen. It's a stacked bar plot where you see the evolution of the radiological changes over time, and the red bars are the ground glass opacity, so they are predominantly present over the whole course of, well, I would say disease over the month that observations were made, but the green bars consolidation becomes more prominent in week 2, then decreasing again. And as already noticed as well, the purple bars are the reticular changes that are developing. And it may reflect some degree of fibrosis, we don't know yet, but we'll have to see whether that's true. Of note is indeed that at the very bottom, the blue bars you see is really very narrow, meaning that about 94% of the patients have CT abnormalities at 1 month after symptom onset. Now, what we note is that this temporal pattern in CT changes of SARS-CoV-2 to some respect coincides with the earlier SARS epidemic that we had, but the difference here is the dark gray bars. There is much more fibrotic changes seen at week 4 and after week 4 in this disease. So COVID-19 bears some resemblance to SARS and MERS. Whether it will apply to functional pattern is not yet clear. However, I took SARS survivors to tell you a bit more about the evolution of pulmonary function that we can expect, since there are no data yet. We're eagerly awaiting the first publications from China on that topic. So what we saw in SARS survivors was, in a way, rather surprising, that pulmonary function seemed to be relatively well preserved over the course of the disease and during the follow-up, as you can see in the graph, of 3, 6, 12 and up to 24 months that have been described. Mild restrictive patterns were initially seen, but spontaneous recovery occurred over the following 6 months. What was more prominent was the mildly impaired carbon monoxide diffusion capacity, which also in a way recovered, but at 3 months still 15% had abnormal diffusion capacity. Exercise tolerance, expressed as for example, the 6 minutes walking distance test, which is a more integrated assessment of cardiopulmonary function, but also musculoskeletal function, and which is more relevant to daily life. This was tested in SARS survivors in several studies and shown to be impaired, although increasing over the course of 6 months. However, 97% of patients had lower 6 minutes walking distance compared to the normal population, and this was present over different age groups. When more advanced cardiopulmonary exercise testing was done, it was noted that also that was impaired in up to 12 months in up to 41% at about 12 months. Now, there was a discrepancy between the pulmonary function. As I said, pulmonary function impairment was only mild. So it was proposed that it is probably a multifactorial causes, and that mainly extrapulmonary dysfunction, such as muscle weakness, muscle wasting, physical deconditioning, were underlying these reduced exercise tolerance. Last but not less important are the worse health-related quality of life that was seen, and this up to 12 months after symptom onset and after discharge. And as you can see in this radar plot, it is basically, well, in different domains, in actually almost all domains, quality of life was lower than the normal. There is some evolution over time, there is some improvement, but it's definitely the functional and the physical domains that lag behind. Again, most likely a combination of factors that play into that. So how will this apply to COVID-19? To be honest, we don't know, because we don't have data. We can compare to SARS and MERS. However, this is a novel coronavirus, and it has shown to behave differently. It's a novel disease entity, so we are all learning by treating. And while the hunt for an effective treatment and the vaccine continues, I think we must ensure that follow-up for those people who have been hospitalized and who are discharged, that we don't forget these patients, because for most of them it's been a bewildering experience, and it is an excellent opportunity to see them again in clinic, to evaluate the course of disease following discharge in terms of respiratory symptoms, but definitely also in terms of radiology and functional testing. Besides that, to assess the impact on physical, mental, social performance and quality of life. And the aim of these follow-up assessments would be to identify patients that are at risk of long-term sequelae, and then to tailor our therapeutic interventions, thinking of pulmonary rehab or other stuff, in a timely and a targeted manner. That was actually all I wanted to say. This is how our clinic consultation waiting room will probably look like in the future. And with this, I wish you a nice evening, and I think the moderator will close the session.
Yes, thank you very much, Nathalie, for your nice and rather shorter presentation, which is very appreciated. And by this we come to the end of the symposium. I again apologize for the technical issues we had at the start of the symposium, but we were a bit victim of our success. I've been told that at peak moments we were just short of 3,000 viewers, so this was quite a lot. You have also noticed due to these technical issues there were no questions, there was no possibility to ask questions, but I think all our speakers did a marvelous job to cover nearly all important aspects of the COVID-19 disease, going from diagnosis over management in low and high care settings to the life after discharge from hospital. So again, I hope you enjoyed the symposium, and I would like to thank you, the audience, for staying with us so late, for your patience, because we were running over time. And one final remark, many people logged in on internet by YouTube, and I've been told that we would try our very best to fix accreditation for these people who didn't log in by the usual way, the Pentalfa site. Thank you very much.